Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 279 of our pharmacotherapy series, which majors in essential hypertension. The first question reads, CSF is a 60-year-old man with hypertension, asthma, and type 2 diabetes mellitus. His hypertension is treated with hydrochlorothiazide 25 mg daily and ramipril 20 mg daily for many years. Today his BP is 148 systolic 74 diastolic. It was 144 systolic 72 diastolic when repeated, and his heart rate is 90 beats per minute. CSF's physician would like to add a calcium channel blocker to his regimen to improve BP control. What are the differences between controlled onset, extended release verapamil and sustained release verapamil? Are they interchangeable? All calcium channel blockers have short half-lives, except amlodipine. Immediate-release forms require multiple daily doses to provide 24-hour effects. Sustained-released formulations are preferred when a calcium channel blocker is used to treat hypertension. Various sustained-release delivery devices are available. Serum drug concentrations differ among sustained-release calcium channel blockers, but overall BP lowering is usually similar. Nonetheless, most of these products that include the same drug are not rated by the U.S. Food and Drug Administration as equivalent and identical. Insurance formularies often encourage therapeutic substitution between these agents. Therapeutic interchange between modified-release drug delivery formulations that allow for once or twice daily dosing, e.g., sustained-release, extended-release, and chronotherapeutic products, however, are not equivalent using a milligram-per-milligram conversion. Therapeutic substitution among these products may result in variable BP-lowering effects if not adjusted appropriately. BP and heart rate monitoring should occur within 2 weeks of interchanging sustained-release calcium channel blockers. The next question reads, is there any clinical evidence on the use of calcium channel blocker in diabetic outcomes? Let's discuss calcium channel blockers and diabetes. Calcium channel blockers have been shown to reduce risk of CV events in patients with diabetes, although the evidence is not as convincing as that seen with an ACE inhibitor. The results of the fosinapril versus amlodipine cardiovascular events randomized trial and appropriate blood pressure control in diabetes trials suggest that ACE inhibitors have more cardiovascular protection than calcium channel blockers. Non-dihydropyridine calcium channel blockers, particularly diltiazem, may slow the progression of chronic kidney disease, although evidence is not as extensive or definitive as it is with an ACE inhibitor or angiotensin II receptor blocker. The proposed mechanism is dilation of both the afferent and efferent arterioles, which would decrease intraglomerular pressure. Dihydropyridines have unclear effects on progression of kidney disease. The prevailing opinion is that the renal protective effects of an ACE inhibitor and angiotensin II receptor blocker are superior to that of a calcium channel blocker. The next question reads, ROR is a 52-year-old man with hypertension for 10 years. He has not yet experienced any hypertension-associated complications or target organ damage. He does not have a history of diabetes and does not smoke. He has been treated with hydrochlorothiazide 25 mg daily, amlodipine 10 mg daily, valsartan 320 mg daily, and carvedilol 12.5 mg twice daily for 1 year. He reports rarely missing a dose of his medications, measures his BP at home every day, and follows recommended lifestyle modifications as diligently as possible. He has tried other medications that resulted in intolerances. With doxazosine he experienced dizziness. With clonidine he experienced dry mouth. His BP has never been less than 140 systolic 90 diastolic, which is his goal. His BP today is 150 systolic 90 diastolic. It was 152 systolic 92 diastolic when repeated. His heart rate is 60 beats per minute, serum potassium is 4.2 milliequivalents per liter, and serum creatinine is 1.0 milligrams per deciliter. He is 183 centimeters tall and weighs 85 kilograms. Does ROR have resistant hypertension? What are his treatment options? ROR has resistant hypertension. JNC8 guidelines recommends that, if goal BP is not reached within a month of treatment of initial drug treatment, increase the dose of the initial drug or add a second drug from one of the first-choice classes of antihypertensives, thiazide diuretic, calcium channel blocker, ACE inhibitor, or angiotensin II receptor blocker. If goal BP cannot be reached with maximal tolerable doses of 2 drugs, add and titrate a third drug from the preferred provided. Do not use an ACE inhibitor and an angiotensin II receptor blocker together in the same patient. If goal BP cannot be reached using only the drugs in the preferred list, because of a contraindication or the need to use more than 3 drugs to reach goal BP, antihypertensive drugs from other classes can be used. Referral to a hypertension specialist may be indicated for patients in whom goal BP cannot be attained using the above strategy, or for the management of complicated patients for whom additional clinical consultation is needed to rule out secondary causes of hypertension. ROR's treatment options are limited. Amlodipine and valsartan are both at the maximal doses. Carvedilol could be increased to 25 mg twice daily, but this should not be done because his heart rate is 60 beats per minute and increasing this dose would place him at risk for bradycardia. It is possible to increase hydrochlorothiazide to 50 mg daily because this higher dose provides larger BP reductions than 12.5 or 25 mg daily based on 24-hour ambulatory blood pressure monitoring. The limitation of this approach is an increased risk of electrolyte abnormalities and metabolic side effects. The next question reads, how safe is it to add lisinopril 5 mg daily or spironolactone 25 mg daily in ROR? For resistant hypertension, 3 global treatment philosophies should be considered. A. Assuring appropriate diuretic therapy. B. Appropriate use of effective drug combination, and C. Use of alternative antihypertensive agents as appropriate. Adding an ACE inhibitor to an already maximum dose of valsartan would not be recommended. The combination of an ACE inhibitor and angiotensin II receptor blocker overall is not very beneficial. This combination should not be used specifically for the purpose of BP lowering, especially in primary prevention patients. When this combination was evaluated in the on-target trial, the ACE inhibitor with angiotensin II receptor combination treatment arm provided only minimal additional reduction in BP compared with either agent alone, and most importantly did not additionally lower risk of cardiovascular events. Moreover, there was a higher risk of adverse events, e.g., kidney dysfunction and hypotension, with the combination arm. The combination of an ACE inhibitor with angiotensin II receptor has been used in patients with left ventricular dysfunction based on promising data of a reduced risk of heart failure hospitalizations. However, the overall clinical benefits of an ACE inhibitor with an angiotensin II receptor versus an ACE inhibitor without an angiotensin II receptor blocker are very small. Addition of an aldosterone antagonist is the preferred next step in patients with left ventricular dysfunction who are already treated with the standard regimen of a diuretic, ACE inhibitor, and a beta blocker. One potential niche for the use of an ACE inhibitor with an angiotensin II receptor is in the setting of chronic kidney disease with significant proteinuria, 300 mg albumin per day or 500 mg protein per day or per gram of urinary creatinine, in which the combination of an ACE inhibitor with an angiotensin II receptor seems to reduce progression of proteinuria better than either drug alone. Many patients with resistant hypertension have a significant component of volume expansion. Detecting this may not be easily observed using routine clinical examinations. However, identifying occult volume expansion using serial hemodynamic measurements from non-invasive bioimpedance testing, followed by enhancing diuretic therapy, has been shown to reduce BP better than treatment selected by an experienced hypertension specialist. Options to assure appropriate diuretic therapy include switching diuretic agents, switching diuretic classes, increasing the dose, or adding a different class of diuretic. Instead of increasing hydrochlorothiazide to 50 mg daily, switching hydrochlorothiazide to the more long-acting chlorthalidone is another possible option to enhance BP lowering. This is an option in ROR. Another option is switching hydrochlorothiazide to a loop diuretic, e.g., furosemide or torsemide. This should be considered for patients with stage 4 or 5 chronic kidney disease, that is a GFR less than 30 ml per minute per 1.73 meters squared, or for those who need diuresis because of edema. This is not a reasonable treatment option for ROR because he does not have chronic kidney disease. Another option is to add an aldosterone antagonist, which is considered an alternative antihypertensive agent. Patients with resistant hypertension often require the use of an agent or agents that is not widely used as either a first or a second-line therapy. These therapies should not be used as monotherapy or a cornerstone of a multidrug regimen because there is less evidence to support their role in reducing cardiovascular events. It should be acknowledged, however, that some of these agents, e.g., reserpine and hydralazine, served as add-on agents to diuretics and beta blockers in early placebo-controlled, stepped care approach trials in hypertension. ROR has already failed to fully respond to, or tolerate, several drug classes that typically are associated with reductions in hypertension-associated complications. To attain his BP goal of less than 140 systolic 90 diastolic, an alternative agent, other than clonidine, should be selected because he did not tolerate it in the past. Let's now discuss alternative antihypertensive agents. We will begin with aldosterone antagonists. Spironolactone and eplerenone are aldosterone antagonists that are especially useful as an add-on therapy in patients with resistant hypertension and would be a reasonable addition to ROR's regimen. Many patients with resistant hypertension have increased activation of the renin-angiotensin-aldosterone system, which can result in increased aldosterone. Moreover, up to 20% of patients with resistant hypertension have primary aldosteronism. These characteristics of patients with resistant hypertension make the addition of an aldosterone antagonist very effective in lowering BP in resistant hypertension. ROR's potassium is in the normal range, but could increase after adding spironolactone. Therefore, it should be monitored 2 to 4 weeks after therapy is started to assure ROR does not experience hyperkalemia. Eplerenone is more specific than spironolactone in aldosterone blockade, although some data suggest that spironolactone is more effective in primary aldosteronism. Compared with spironolactone, gynecomastia is less frequent with eplerenone. The incidence of hyperkalemia may be greater with eplerenone, however. When used for hypertension, eplerenone is contraindicated in populations at high risk for hyperkalemia, including patients with an estimated creatinine clearance of less than 50 ml per minute or elevated serum creatinine, that is above 1.8 mg per deciliter in women and above 2.0 mg per deciliter in men. The next question reads, how beneficial would more intensive lifestyle modifications be in ROR? In addition to non-adherence with drug therapy, lifestyle factors, such as obesity, sodium ingestion, and heavy alcohol intake, are a significant contributor to resistant hypertension. Lifestyle modifications should continually be reinforced in patients, especially those with resistant hypertension. As previously discussed, these modifications should include dietary changes and physical activity. ROR should be instructed to restrict his daily sodium to less than 1.5 grams because this has been shown to decrease SBP by more than 20 mm of mercury in resistant hypertension. JKL is a 64-year-old man with hypertension. His BP is 158 systolic 84 diastolic. It was 156 systolic 86 diastolic when repeated. His current antihypertensive regimen is hydrochlorothiazide 25 mg daily, irbesartan 300 mg daily, and nifedipine extended release 60 mg daily. JKL is not completely adherent with lifestyle modifications, but insists he is doing the best he can. He has been experiencing frequent nocturia, difficulty in starting urination, and a decrease in his urinary flow for the past several months and is diagnosed with benign prostatic hyperplasia (BPH). JKL's physician is considering changing one of his antihypertensive agents to an alpha blocker. How do alpha blockers compare with other agents in reducing cardiovascular events? Alpha blockers are not first-line agents in the management of hypertension. The ALL-HAT trial originally included an alpha blocker doxazosine treatment arm. Interim results after a mean follow-up of 3.3 years revealed that doxazosine had a statistically higher risk of combined cardiovascular disease and heart failure when compared with chlorthalidone. Therefore, the ALL-HAT data show that chlorthalidone was more effective in lowering some hypertension-associated complications than was doxazosine. This study did not include a placebo group, therefore, to conclude that doxazosine is harmful is inaccurate. For JKL, discontinuing hydrochlorothiazide, irbesartan, or nifedipine to start an alpha blocker is not prudent. It may be appropriate, however, to add an alpha blocker to his regimen. An alpha blocker will also have a benefit on his BPH. The next question reads, how can an alpha blocker improve JKL's BPH? The smooth muscle surrounding the prostate is innervated by alpha-1 receptors. By blocking these receptors, an alpha blocker can improve the symptoms of BPH by reducing urethral tone and alleviating bladder outlet obstruction. Terazosin and doxazosine are both approved for the treatment of BPH. Prazosin should not be used because of the need for frequent dosing. Improvements in BPH symptoms with alpha blockers are dose-related. A high dose is often needed, and this increases the risk of side effects, such as orthostatic hypotension. In JKL, an alpha blocker will lower his BP and improve his urinary symptoms. The next question reads, JKL prefers to try doxazosine rather than undergo surgery to relieve his symptoms of BPH. How should this agent be started? For JKL, it would be best to add a low dose of doxazosine to his present regimen. Based on his BP response and tolerance, the dose can be titrated up. One of his other antihypertensive agents can be decreased if he becomes hypotensive. The initial dose of doxazosine should not exceed 1 mg daily and it should be given at bedtime. This can minimize orthostatic hypotension, which is the most frequent side effect of alpha blockers. This complication is most pronounced with the first dose, but can persist in some patients. Moreover, if an alpha blocker is selected as add-on therapy in patients like JKL with resistant hypertension, nighttime administration of an alpha blocker has been shown to be effective in further lowering BP. The next question reads, how should JKL be counseled regarding side effects of doxazosine? Alpha blockers are well tolerated if dosed appropriately. JKL could experience side effects, such as drowsiness, headache, weakness, palpitations from reflex tachycardia, and nausea, but these do not occur in all patients. Patients starting an alpha blocker should be instructed to take the initial dose at bedtime and to anticipate the first dose effect of orthostatic hypotension. Specifically, patients should be counseled to rise more slowly from a seated or supine position. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 280.